Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Students' Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in International Medical Congress of Silesia 2024. My name is Miłosz Kasprzyk, and I have an honor to coordinate non-invasive cardiology session. I would like to cordially welcome the esteemed jury, President of the jury, Professor Tomasz Kukulski, and members of the jury, Professor Beata Średniowa, Associate Professor Krzysztof Szydło, Associate Professor Jolanta Nowak, Dr. Artur Filipecki. We would like to explain to you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for the presentation is 7 minutes and the 3 minutes for the discussion. If the presenter exceeds the time, one needs to move on to the conclusions and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. I would like you to remind that every work must be presented in English. We kindly ask the jury to assess scientific value, way of presenting, discussion, and all contribution on a scale from 1 to 5. When the session ends, we kindly ask you to give the cards back to the coordinator. To begin, I think we can start with the first presentation. I would like to ask to present the paper titled Assessment of Mitral Valve Regurgitation in Patients with Severe Aortic Stenosis Qualified for TAVI. If the presenting author is ready, please feel free to start the presentation.
Ladies and gentlemen, my name is Alicja Pawlus, and today I would like to present you a topic, which is assessment of mitral valve regurgitation in patients with severe aortic stenosis qualified for transcatheter aortic valve replacement, which is TAVI. The work's tutors are philosophy Dr. Witold Strep and Professor Beata Średniowa. For those who don't really know what the aortic stenosis is, I will tell you briefly and then we can move to the next part of the presentation. So the aortic stenosis is a common valve disease that leads to the left ventricular outflow obstruction. The incidence of aortic stenosis increases with age and reaches 45% of patients around 8 years of age. The etiology of aortic stenosis may be congenital, unicuspid or bicuspid aortic valve, rheumatic disease of AV, and the AV calcification. There are some symptoms that are in aortic stenosis, such as chest pain, syncope, fatigue, and the screening test for aortic stenosis is echocardiography. The treatment for aortic stenosis is TAVI, which is transcatheter aortic valve replacement, or a classical surgery. The common coincidence associated with aortic stenosis is mitral regurgitation, and that leads to our aim of the study, which is to determine the frequency, the type, and the determinants of mitral regurgitation in patients with severe aortic stenosis qualified for TAVI. Our study includes 54 consecutive patients with severe aortic stenosis qualified for TAVI, hospitalized in the first Department of Cardiology STCS Zabrze from November 2023 to February 2024. 26 of our patients were female and 28 patients were male. Echocardiography was performed in all patients. The echo examination was performed using Vivid E95 and the analysis was carried out at the echo pack station. During our research, we have assessed parameters of mitral regurgitation such as range, jet field, and ROA, which is effective regurgitant orifice area. Here we can see a parastellar projection, and here we measured aorta, which is here, a left ventricle, a right ventricle, and note that the intraventricular septum is thickened and the aortic valve is calcified. This is also a parastellar projection where we measured LVOT diameter, and it is really important to have it to then measure aortic valve area. Here is an example of a patient with severe aortic stenosis. Here we can see a 5-chamber view, and to have an aortic valve area, we need LVOT dimension that I mentioned before. Also, a VVTI, which is here, and LVOT VTI that we can measure here. To obtain a VTI, we used a continuous wave Doppler, and to obtain LVOT VTI, we used a pulse wave Doppler. In this example of 5-chamber view, we can see a severe calcification of mitral valve, and so we can classify the patient for type 3A of mitral regurgitation. Here we can see a severe mitral regurgitation with type 3B because there is a restriction of mitral valve. This is a patient with severe mitral regurgitation with type 3E, and here there is a fibrosis on mitral valve. This is an example of how we can measure the ROA. And to obtain the ROA, we only need 2 parameters: the peak velocity of mitral regurgitant jet and the pizza diameter. And note that aliasing velocity should be between 0.3 to 0.5 centimeters per second. Quantitative data are presented as means and SDS. Qualitative data as counts or percentages. To compare groups for quantitative variables, the Mann-Whitney test for ANOVA, Kruskal-Wallis is used, and for qualitative variables, the chi-square test. The significance level of p below 0.05 was taken as significant. This table shows a comparison of echocardiographic and clinical factors depending on the grade of mitral regurgitation. And the echocardiographic parameters we measured were left ventricle and diastole and systole diameter, the left ventricle and diastole and systole volume, ejection fraction, right ventricle diameter, and right ventricle systolic pressure. The other parameters are the mean gradient of aortic valve, the aortic valve area, and when it comes to clinical factors, it was the GFR, glomerular filtration rate, the diabetes mellitus, and the arterial hypertension. In the study population, the mean area of aortic valve was 0.66 plus minus 0.18 quarter centimeters. The mean AV gradient was 43.7 plus minus 12.3 millimeters of mercury. MRI was observed in 40 patients. The mild MR occurred in 24 patients, moderate MR in 14 patients, and severe MR in only 2 patients. Moderate and severe mitral regurgitation were significantly more common in women than in men. And according to the Carpenter's classification, the type 3A was the predominant type, which occurred in 22 patients. 18 patients had the type 3B. And the conclusions, the MR is a common valvular disease co-occurring in patients with severe aortic stenosis. The dominant mechanism of MR is type 3A, and in patients with severe aortic stenosis, the frequency of mitral regurgitation was similar for women than in men, but women had significantly more advanced mitral regurgitation than men. And thanks for your attention, and feel free to ask some questions.
Thank you for your presentation. And now I think we can proceed to the discussion.
Thank you. So let me start the discussion. This is an interesting clinical topic concerning the mixed valvular disease. You presented the baseline data showing us the percentage of concomitant mitral regurgitation. 3A, according to Carpentier class, it means that the etiology of this valvular lesion is organic, so it's mostly calcified mitral valve. Did you try, or maybe you plan to look for outcome of this patient? Because the clinical importance of your work is that we would like to know whether correction of aortic stenosis by performing aortic replacement or implanting the TAVI valve will also correct the mitral regurg. So my question is whether you have an opportunity to look at follow-up of this patient, whether this mitral regurg was reduced after intervention or did not reduce?
Yes, of course. Now we are looking for some follow-up, and the patients that were qualified for TAVI, some of the patients have this surgery, and we are going to make a new research for this patient. But for now, we have only a few patients that are after the TAVI.
One only small remark. You have divided this population of matter regurgitation to mild, moderate, and severe. And as I noticed in your results, the severe is only 2 patients. Maybe it will be more useful to include, to make this one group of moderate and severe. It will be maybe more useful for just a remark. Okay, thank you.
Thank you for excellent presentation, very educative. I would like to ask you about low flow, low gradient, severe aortic stenosis, especially in patient with heart failure with preserved ejection fraction. And which one of parameters, echocardiographic parameters, for your opinion, is the most powerful?
So when we want to classify patients as a severe aortic stenosis, we can look at the mean gradient on aortic valve, but it is not enough to classify the patient, because if the mean gradient is below, we can also look at the left ventricle diameter and the left ventricle volume. Also the stroke volume, when it's below 60 millimeters, we can tell that the patient has a severe aortic stenosis, even if the ejection fraction is preserved.
Thank you.
Okay, thank you. If there is no further, there is another question.
Yes, I have one question. It's a question for you, and I will ask for next speakers. We have the point your own contribution in the study. So I would like to ask you about this contribution, and may we ask next speakers to give us this information at the end of our presentation. Okay.
Okay.
So what was your contribution?
What was your contribution in the study?
So we had analyzed the patient in the APAC station, and we also saw some echocardiographic examination, and then we discussed our results with a philosophy doctor, and then we make an analysis of this. So thank you.
Now I would like to ask to present the paper entitled Characteristics of a Patient with Atrial Fibrillation. Are VKAs still in the game?
Hello everyone, my name is Natalia Murowana. I'm a third-year medical student at the Medical University of Silesia, and today I'm here to discuss the characteristics of patients with atrial fibrillation with a special focus on their anticoagulant treatment. Atrial fibrillation is the most common cardiac arrhythmia characterized by disorganized, rapid, and irregular atrial electrical activation. In 2020, over 33 million people worldwide and nearly 700,000 people in Poland were affected by this condition. The aim of our study was to evaluate the clinical characteristics of patients with diagnosis of atrial fibrillation in relation to their anticoagulant treatment. We analyzed medical records of 101 patients admitted to the first department of cardiology at the Upper Silesian Medical Center in Katowice in 2023 with a diagnosis of atrial fibrillation. We focused particularly on the anticoagulant medications that patients were taking prior to the hospitalization. Among the analyzed individuals, half of them were males. Over half of them were males. Their average age was 67 years, and most of them were overweight or obese. The study was conducted using retrospective methods. When analyzing the patients, we focused on types of anticoagulant treatment they were receiving and whether the dosage of those medications was appropriately adjusted. Additionally, we examined how many patients underwent ablation, whether they had experienced some thromboembolic events in the past, and which comorbidities they suffered from the most. According to the guidelines of European Heart Rhythm Association from 2021, when considering whether the dosage is appropriate for the patient's condition, we took into account factors such as age, body mass, BMI, Has-Split scale, renal function, and patient's blood counts. Now let me quickly mention a few other things we discovered while looking at their medical records. We observed that the majority of patients had hypertension and hyperlipidemia, and nearly half of them suffered from heart failure. Speaking of previous thromboembolic events, we can notice that they do not affect a large number of patients, but the most common was myocardial infarction. During their hospital stay, 65% of the patients underwent ablation. And now let's move on to their anticoagulant therapy. In an analyzed group, over 80% were on NOACs, with over 74% received them as a monotherapy. Almost 5% were on VKAs, and nearly 15 patients were on other medications such as antiplatelet drugs or were not treated at all. Taking a closer look on NOACs, as you can see, most patients were on a full dose of rivaroxaban, and half of the patients on dabigatran had their doses reduced. There were only 5 patients treated with VKAs, but surprisingly, 60 of them might have had the wrong dose of medication because their INR levels were below 2. Speaking of NOACs, only 17% had incorrectly prescribed doses. In 6 cases, dose was too low, and in 9 cases, dose was too high. Considering the Katowice scale, we can see that out of 13 patients with a score of 2 or higher, 11 should be on anticoagulant therapy because they have a high risk of thromboembolic events in the future. To sum up, among the few patients on VKAs, most of them might not have been getting the right treatment, which wasn't really as much of a problem for those on new generation drugs. For patients who weren't receiving any blood thinning treatment, it would be rather necessary to monitor their health more frequently to avoid the moment when anticoagulant therapy might become highly recommended for their health. And thank you for your attention. And I would like to say what was my impact in the study. So I was assigned for mainly collecting data. I was preparing the abstract, and now I'm presenting the study for you. Thank you.
Okay, thank you for your presentation. Now we can move to the discussion.
Anticoagulation therapy is very important in atrial fibrillation, so the topic is also important, but I have some remarks because this is a pretty small group of patients, and preferably patients were qualified for ablation. So it is not surprising that almost whole group was on anticoagulation. So I think that it will be more valuable work when you done the analysis, for example, from 2 or 3 years, because the group of 100 patients with atrial fibrillation it is a very small group. So it is difficult to draw the conclusions. But conclusions are in line with old trend worldwide to replace NOAC of VKAs. So I think that will be very interesting when you expand the investigator group.
Thank you.
Yes, it was a very fine paper, and my first suggestion is that you had a rather small group, so I think that the conclusion that NOACs are more effective than other oral anticoagulation is maybe not very good, because it's too small group, and you don't have long follow up for this patient, so you can't say something like this. And as I remember, about 6% of these patients had dual therapy, so NOACs and antiplatelet therapy. Can you say in this group it was about I think 4 or 5 patients, maybe 6 patients, I don't know, because I remember percentage. And can you say something more about these patients? Why double therapy in these patients? Why this antiplatelet therapy?
I'm not sure, but I think they had some maybe myocardial infarction past, and they had prescribed the antiplatelet drugs, and maybe that was the case, that they have both. And the second drug, the NOACs, were prescribed for atrial fibrillation, but I'm not sure what was the real reason for them.
Now I would like to ask to present the paper entitled CT-derived myocardial extracellular volume fraction, redundant by product or an over-promising marker.
Hello everyone, dear committee. My name is Jakub Nowak and I'm from Jagiellonian University from Krakow, and I would like to present you our study about CT-derived extracellular volume from myocardium, in which we want to decide is it only redundant by product or a novel promising marker. But first of all, what is ECV? ECV value is percentage of myocardium presented by elements other than muscle cells. Normal ECV value obtained from patients without cardiovascular diseases range between 20 to 30%, and ECV expansion is associated with myocardium dysfunction such as fibrosis, inflammation, or amyloid deposition. And in our study, we search for clinical or echocardiographic correlates between from CT-derived ECV from real-world patients. This is possible thanks to Bandula and others who develop special formula for this. They use measurements from myocardium and blood in Hounsfield units. Then they compare them and correct these values by hematocrit. Today, ECV is mostly assessed by MRI, which enables us to detect both focal fibrosis and diffuse ECV expansion. But as we know, MRI is very time-consuming and expensive, and we try to assess, is it possible to assess ECV in CT scans. It can be also be very good diagnostic alternative for patients with contraindications for MRI. And we retrospectively assess ECV from archived CT scans, and we assess also echocardiographic from over 100 patients, exactly 103. Half of them was women, and their mean age was 66 years. Almost 60% of them had hypertension, and quarter of them had diabetes type 2. Our main inclusion criteria was interval between CT scan and echocardiography shorter than 1 year. So if this interval was longer, we disqualified our patients. And how we did that? First of all, in CT scan from heart, in arterial phase, sorry for my hand, we found intraverticular septum, which is the easiest way because it's very clearly seen. And then our program find the same exact point in native phase and delayed phase. We also take measurements from blood, and then we verified these values manually. My colleagues calculates an extended set of left ventricular structure and function parameters, including diastolic and systolic velocities of mitral annulus. Here you can see every parameters they checked. And now let's talk about our results. As you can see, mean ECV fraction was 25.2, and it was followed by Gaussian distribution. As you can see in the table, there was no significant correlates from echo or clinical status of patient and ECV. However, when we divided our group into over median ECV fraction and below median ECV fraction, you can see positive correlation between S prime and E prime, which are parameters of early diastolic and systolic left ventricular parameters. And what does it tell us? ECV might be correlate with mutual interdependence of E prime and S prime. And when fibrosis is strong enough, it correlates, it influences S prime and E prime positively. But when ECV is too low or not strong enough, other factors like contractility interfere with this relationship, and we can see the relationship between E prime and S prime. And how we can use our results, keeping in mind expanding use of cardiac CT scans, we can get better insight into left ventricular mechanics, especially in long axis. And our results can be base for large scale studies in which we can assess is ECV a good parameter as an endpoint of many myocardium diseases. And that's all. Thank you for your attention. My contribution into our work, I studied every CT scan. I also make a database from last 2 years. And my colleagues assess every echocardiographic parameters. Thank you.
Thank you for your presentation. Now we can proceed to the discussion.
Thank you for presenting your work and for your important contribution to analyze the CT scans. I think that the topic is important, clinically important, because extracellular volume could be the potential marker of, as you said, first of all, fibrosis, and it could be also a potential indirect or maybe direct marker of sudden cardiac death. We know that already some of MRI information from late enhancement gadolin assessment has been introduced as a valuable marker of sudden cardiac death, specifically in patients with hypertrophic cardiomyopathy. So actually there is a potential in the work you have done. My question is, because you did the correlation between your measurements and selected echo measurements, why did you select specifically the tissue Doppler velocity data? It means early diastolic or myocardial velocity or systolic velocity, this regional velocity data. Did you maybe think, or maybe you are going to do this, to correlate your findings with the strain analysis? Because the strain echo, now it's a widely used parameter, and we know that strain imaging derived from echo measurements has a potential as a marker of fibrosis.
Yes, we are looking forward to check that, but now in our study we use only archived echocardiographic and CT scans, so it was impossible. But now when we have large database, we will for sure continue that work.
Do you think it makes sense to make such a correlation with strain, the global strain, or the distribution of strain?
Yes, as I said, MRI is very expensive and time-consuming, and in the real world, there is only one doctor in the hospital who can assess that. So I think when we will have CT scans and strain echocardiography, it will be easier for other cardiologists to assess these patients.
Yes, more cost effectiveness. Thank you for your presentation, for the topic, for me, fantastic topic, new point of view. And I agree with my colleagues that strain would be better and more efficient. And I encourage you to the next step and continue your study. Thank you.
Okay, thank you. Now I would like to ask to present the paper entitled "The expression level of MIR10B increased in patients with unstable angina compared to CCS."
Good morning, ladies and gentlemen. It's an honor to have the opportunity to address such a distinguished audience. My name is Dane Kim. I'm a South Korean student studying at Medical University of Warsaw. And today I'm going to present the research expression level of MIR10B increased in patients with unstable angina compared to chronic coronary syndrome. To introduce, acute coronary syndrome is characterized by thin fibrous cap and lipid-rich necrotic core, which increases the risk of the rupture of the plaques. On the other hand, chronic coronary syndrome is characterized by stable atherosclerotic plaques. Acute coronary syndrome causes a sudden reduced blood flow to the heart that may lead to necrosis of the heart muscles, which is called myocardial infarction. Acute coronary syndrome can be caused by unstable plaques, which may lead to rupture of the plaques and aggregation of the platelets. This may lead to the formation of the thrombus and occlusion of the coronary artery. Acute coronary syndrome without necrosis is called unstable angina, which is one of the main topics of our study. Acute coronary syndrome is divided into ST-elevated myocardial infarction and non-ST-elevated myocardial infarction and unstable angina. Myocardial infarction is the damage of the heart muscles which releases troponin from the muscle cells into the bloodstream. We're moving on to the aim of the study. The aim of our study is to compare the expression level of MIR10B, which downregulates the Krupfel-like factor 4. Krupfel-like factor 4 is known to be one of the important inhibitor of arthrogenesis. 10 patients with unstable angina and 12 patients with chronic coronary syndrome and 10 healthy volunteers have participated in our study. For materials and methods, qPCR technique was used to measure the various expression level of microRNAs. Vulnerable plaques were assessed clinically, and every patient with unstable angina and chronic coronary syndrome was diagnosed by coronary angiography. These are the images during the angiography and its analysis. Angiograms were made during the stenting procedure. This is the example image of the qPCR machine, which was used to measure the various expression level of the microRNAs. The patients were divided using the clinical diagnosis of angina. The group of patients with unstable angina had acute pain with angiography within 24 hours from the admission. And for a group of patients with chronic coronary syndrome, had the planned diagnosis for the diagnosis without any acute symptoms. And for healthy volunteers, they had no diagnosed diseases and also no chronic diseases. Some of the patients were excluded from the study, and the exclusion criteria were no history of myocardial infarction and without cardiac implants or without diabetes or other serious comorbidities that might affect the results of the study. The characteristic of the participants. So a group of 10 patients with unstable angina were aged around 65 years old with BMI approximately 30. And 10 patients and 12 patients with chronic coronary syndrome were aged around 70 years old with BMI around 25. And healthy volunteers were aged around 40 with BMI around 25. Now I'd like to share with you the results. The results have shown that expression level of miR-10B in the group of patients with unstable angina was 0.069. And the expression level of microRNA miR-10B in the group of patients with chronic coronary syndrome was 0.042, which leads to the probability of 0.003. In the group of patients with chronic coronary syndrome, the expression level of miR-10B was 0.042. And for healthy volunteers, it was 0.085, which leads to the probability of 0.01. These are the results summarized in the table form. And we are moving on to the conclusions. To conclude, the study has revealed that in patients with acute coronary syndrome, which is characterized by unstable plaques, there's an increased level of miR-10B, which is the downregulator of cryptoglycan factor 4. This finding might indicate that the miR-10B's possible role in the process of the destabilization of the plaques. Whereas increased level of miR-10B in the healthy individuals might reflect on its role of cryptoglycan factor 4 regulation in the physiological process of the healthy individuals, especially in the younger age. So that brings me to the end of my presentation. Thank you for your attention, and if there's any questions, I'm happy to answer them.
Thank you for your presentation. We can now proceed to the discussion.
Okay. Congratulations for your work. I must say this is somehow the pioneering work because we already have some data about microRNA in cancer, also in heart failure patients, but we data on pathogenesis of atherogenesis. and specifically in pathogenesis of acute coronary syndrome. Also, this is a very small sample of patients. The doubts that I have from your result is that it might be the microRNA will be not sufficiently specific in the assessment of any prognostic value, because as you saw also in healthy young volunteers, the level of expression was as high as in patients with acute unstable angina with unstable plaque. What will be your comments to this result?
I would say that the difference between the acute the unstable angina and chronic coronary syndrome, the expression level and the probability was quite significant. And for healthy individuals, and the comparison between the healthy individuals and chronic coronary syndrome, it's more to be investigated, but perhaps it would be due to the physiological process and also due to the characteristic of the healthy individuals, which are quite younger compared to the patients with acute coronary syndrome and chronic coronary syndrome. It was quite difficult to find the patients who were around 70 years old without any diseases, so the nature of the healthy individuals were quite younger.
And this analysis was done based on a blood sample, or you take the data from the tissue sample?
It was done by the blood sample. Yeah, we did the qPCR test using the centrifugation and the...
And what was your contribution to this work?
My contribution was assisting in the analysis of the coronary angiography during the patient selection, and also making the patient database and calculating the values of the patient characteristics, and making the slides and the abstracts and presenting it. Yeah.
Thank you.
Thank you.
So my question is, because you shown that you excluded from your study patients with diabetes and others comorbidities which are very common in patients with coronary syndromes. So it is not representative group for coronary heart disease. So why did you exclude these patients?
So we excluded the patients, for example, like diabetes, due to the reason that diabetes affects the nature of microRNAs and their environment, which my presentation was mainly about the destabilization of the plaques in relation to MIR10B. So to focus on that, we excluded every patient that might affect the nature of the microRNAs. So we excluded the serious comorbidities and also diabetes and history of myocardial infarction. So it was quite specific, I would say.
So the method will have a lot of limitations.
Okay. Okay. Okay.
Okay, thank you.
Thank you.
Now I would like to ask to present the paper entitled Assessment of Obstructive Sleep Apnea in Patients with Pulmonary Arterial Hypertension.
Good morning, ladies and gentlemen. My name is Julia Dołęga, and today I would like to share with you the results of our clinical study about assessment of obstructive sleep apnea in patients with pulmonary arterial hypertension. As we know, obstructive sleep apnea is associated with temporal hypoxemia that may lead to pulmonary arterial hypertension. It has been observed that patients with PAH often report symptoms like chronic fatigue, daytime sleepiness, and numerous night awakenings. The condition for diagnosing the disease is the observation of at least 5 apneas and/or hypopneas per hour of sleep, accompanied by excessive daytime sleepiness and at least 2 of the following symptoms. Pulmonary arterial hypertension develops through several probably pathomechanisms presented on the slide. Our aim was to analyze the prevalence of obstructive sleep apnea and relevant parameters among patients diagnosed with PAH. Materials and methods. Our methods include polygraphy, a 6-minute walk test, and the analysis of gathered parameters such as coexisting diseases, echocardiography parameters, medicines, and laboratory tests. We performed tests using a polygraphy apparatus which allowed us to monitor breathing effort of abdomen and chest, airflow through the nasal cannula, body position, SpO2, heart rate, and plethysmography using a pulse oximeter. Here is our patient wearing the earlier mentioned polygraphy apparatus. And example of the test results. Characteristic of the study group. We collected data of 20 consecutive patients with pulmonary arterial hypertension, including 5 males and 15 females aged about 63 years old. The most common type of PAH among patients was idiopathic in nature. The group was divided according to apnea-hypopnea index into group with AHI less than 5, which accounted for 9 patients, and HAI more than 5, which accounted for 11 patients. Among the patients assessed, 1 was classified as grade 3rd obstruction, 4 were categorized as grade 2nd, while the remainder fell into the grade 1st classification. And now I will present the results of our study. As mentioned previously, the entire patients cohort was initially divided into 2 subgroups, which were subsequently compared in further analysis. There were no statistically significant differences between both groups regarding age, height, weight, BMI, or BSA. Baseline characteristic showed that the number of coexisting disease was comparable in both groups. However, group with AHI less than 5 tended to have a higher incidence of venous thromboembolism. The results of the 6-minute walk test indicate poorer outcomes among patients with AHI more than 5, particularly evident in the case of diastolic blood pressure prior to the test. Among echocardiography parameters, statistically significant were septum thickness and MVV max. Here you can see a part of TT from one of our patients. In the context of medication, we did not observe any differences. In the group of patients with AHI more than 5, elevated PTW levels were noted, along with shortened EPTT and PT times, suggesting serious implications. Furthermore, higher sodium values were also observed within this group. However, as expected, the results of polysomnography were as follows. patients with diagnosed obstructive sleep apnea demonstrated markedly worse parameters in comparison to those without such observation. To sum up, obstructive sleep apnea occurs in 55% of PAH patients, requiring polygraphy for diagnosing and symptoms elevation. Elevated PDW levels and shortened APTT and PT times in this group may act as predisposing factor for thromboembolic events and progress of PAH. So, remember, it is important to look for obstructive sleep apnea signs in patients with PAH. Thank you for your attention and feel free to ask us any questions.
Thank you for your presentation. We'll move to the discussion now.
And maybe I'm gonna start and talk about our contribution in this work. We tried to do everything as a team. So our work was to contact with a patient, to collecting a database and expand it by the new ones, to performing the 6-minute walking test and polygraphy, and to making this presentation and whole abstract. Thank you.
Do we have any questions?
And thank you and congratulations for your presentation. And do you suggest that we should do this diagnosis for all patients with PH?
Thank you for your questions. Yes, we think that obstructive sleep apnea is common disease in population, but especially in the patients with pulmonary arterial hypertension, is important to diagnose it because it could provide to worse prognosing for pulmonary arterial hypertension and depression and more consequences like daytime sleepiness and more like this.
And worsening quality of life.
Yes,
I think.
Exactly.
Yes, and for me, this is the main clinical conclusion. Thank you.
Thank you.
What will be your attitude and to this problem? Because we still do not have evidence that actually sleep apnea is the reason of pulmonary hypertension. On the other way, we see that pulmonary hypertension could be a result of sleep apnea. So there's ongoing question: what was the first, egg or chicken?
Thank you for your question. I think it's difficult to answer this question because in some cases, a patient with obstructive sleep apnea it could be provide pulmonary arterial hypertension or in other way, but I think we have to collect more database and check it in the future. But it's difficult because pulmonary arterial hypertension is a rare disease and it's difficult to collect larger database. For example, 20 patients was collected by more than 1 year. So it's difficult to answer this question.
But anyway, congratulations for the concept of this work. Yeah.
We've got one more question.
Just a moment. Yeah, very short question because sleep apnea, especially obstructive sleep apnea, is regarded as a prodrome of atrial fibrillation. Have you any data about atrial rhythm disturbances, especially atrial fibrillation episodes in this group?
We analyzed this parameter, but it's not statistically significant, so we don't analyze more than whole statistics. Atrial fibrillation, if I remembered, was in 19 patients, if I remember correct, but it was not statistically significant, so we don't analyze it more deeply. Yes, exactly.
So 19 patients, it's about 20%, 25% of patients?
19 patients from,
yes.
From 20 patients has atrial fibrillation.
So it was very common, yeah?
Yes.
And do you think that this atrial fibrillation can influence the results of polysomnography?
Yes, but every patient has treatments for atrial fibrillation and have any episodes of it during...
So many other way. All this polysomnographic examination was performed on sinus rhythm?
No. No.
So you had also patients with chronic atrial fibrillation?
We analyzed
maybe you have no data about it. So it's
we have AKJ results and the history of patients, and in this history, patients have atrial fibrillation, but it's only retrospective analysis, but polygraphy don't give us information about atrial fibrillation, so I couldn't answer this question exactly, but as I mentioned, patients has atrial fibrillation in his history.
Thank you very much.
Thank you.
Okay, now I would like to ask to present the paper entitled Supraventricular Arrhythmias in Patients with Acute Ischemic Stroke and RIND Episodes.
Good morning, ladies and gentlemen. My name is Agnieszka Pratyka, and I'd like to present our work called Supraventricular Arrhythmias in Patients with Acute Ischemic Stroke and RIND Episodes. Here we have a brief presentation plan. Stroke is the second most common cause of death and the first cause of disability among adults. Approximately 75 to 85% of all strokes are ischemic strokes. In 2022, in Poland, 73,900 cases of ischemic stroke were reported, and 89% of them were first-time strokes. Regarding cerebral cardiogenic embolism, the most common causes are occlusions of cerebral arteries. Among supraventricular arrhythmias, atrial fibrillation is a known risk factor for ischemic stroke, and SVA, meaning excessive supraventricular ectopic activity, is considered to be the prodrome of atrial fibrillation. With that in mind, we aimed to analyze the presence of different forms of supraventricular arrhythmias in patients with various brain ischemic episodes. In order to do so, we gathered data from one-day Holter recordings in the first week after acute ischemic episodes and medical history of 675 patients hospitalized in the Department of Neurology between 2018 and 2021. The patients with other conditions than TASI, non-TASI, or RIND were excluded from the cohort. Let me explain the meaning behind these abbreviations. TASI means total anterior circulation infarct. Non-TASI includes strokes other than TASI, for example, listed on the slide, partial anterior or posterior circulation infarct. RIND and TIA are reversible ischemic neurological deficits, which resolve typically up to 72 hours after onset. Our study cohort of 573 patients was divided into 3 groups, and the mean age of the patients was 70.9. Amongst CHA2DS2-VASc score components, besides stroke, the most common comorbidities were hypertension and vasculopathies in its broad sense, mostly coronary artery disease. You may notice that the percentage of elderly patients above the age of 75 equaled only 27%. Moving on to the results themselves. Our groups did not differ in terms of given parameters except for NIHSS, and I will elaborate on this topic in the next few slides. Regarding differences in gender predominance, the majority of patients with TASI were men. In contrast to RIND group, where 58% were women. The groups did not differ in terms of age. Interestingly, the groups were comparable in terms of CHA2DS2-VASc score, and a positive correlation with age was observed. There was also a group of 46 patients where stroke was the only comorbidity. And patients with atrial fibrillation had higher average age, and almost 71% of these patients were over the age of 75. The highest mean NIHSS was in the TASI group and the lowest in the RIND group. In one-day Holter recordings, supraventricular arrhythmias, such as premature atrial contractions, ectopic atrial tachycardia, and atrial fibrillation was observed. In this study, we also aimed to analyze the presence and frequency of excessive supraventricular ectopic activity. Therefore, based on the literature, we defined SVA as more than 30 premature atrial contractions per hour, or ectopic atrial tachycardia with more than 20 QRSs, or more than 720 premature atrial contractions. The groups were comparable in terms of mean heart rate. Average number of premature atrial contractions was the lowest in the RIND group, in contrast to ectopic atrial tachycardia, where in the mentioned RIND group, the average number was the highest. SVA was observed in 200 patients, and that makes 34.7%. The highest percentage was observed in the non-TASI group and the lowest in the RIND. In terms of atrial fibrillation, the highest percent equaled almost 12% and was observed in the TASI group, and the lowest applied to RIND patients, reaching 3%. In total, atrial fibrillation was observed in 9% of the patients. Arrhythmic events, meaning atrial fibrillation or SVA, in total was observed in 220 patients, which gives us almost 40% of the population. The occurrence of these arrhythmic events was significantly lower in the RIND group. In conclusion, one-day Holter recording allowed the diagnosis of atrial fibrillation in 9% of the patients in the first week after stroke, and the frequency of supraventricular arrhythmias, especially for SVA, is interestingly high. Then the differences in various locations of stroke were observed, and these arrhythmias were observed significantly less frequently in patients with RIND. Among brain ischemic episodes, the majority of the patients in TASI and non-TASI were males, in contrast to RINT, where 58% were females. We are still gathering the follow-up for the patients and are trying to answer the questions that came to us in the course of preparing this study. And thank you all for your attention. Now I'd like to invite my colleague on stage and all of you to ask some questions.
Thank you for your presentation. Can you tell us what was your contribution to the work?
Yes, firstly, we reviewed the literature on supraventricular arrhythmias and strokes. Then we gathered data from one-day Holter recordings and from the medical records of the patient hospitalized in an exact department of neurology. And then we took part in the statistical analysis and prepared this presentation to share our results with all of you.
Thank you. Now we can move to the discussion. Are there any questions? Okay, there are no questions, so thank you for presentation. Oh, okay, sorry.
So congratulations for the topic, because it is still unknown what is the connection between stroke and the time of to discover, for example, atrial fibrillation. And so you showed that in around 9% of the patient in the first week after the stroke, you discovered it was new discovered atrial fibrillation, or it was the confirmation of atrial fibrillation? What was the kind of atrial fibrillation?
Thank you for this question. Our group excluded patients with previous history of atrial fibrillation, so it was new discovery, and our study was based on one-day Holter recordings, while longer continuous Holter monitoring is recommended for detection of atrial fibrillation. For example, in the USA, it is 30 days of continuous monitoring. So our 10%, almost 10% detectability was new discoveries of atrial fibrillation.
Did you repeat Holter monitoring after this 1 week, or it is only one Holter monitoring?
For now, we gathered information about only Holter recordings in the first week after acute episodes, but we are gathering the follow-up about the treatment of the patients, about the mortality and recurrent strokes. So we are we will be checking that if the patients had other Holter monitor tests.
Okay. Thank you.
Thank you very much.
One question more. Could you go back to the results?
I don't know, because yes, maybe I can.
Okay. So you. No?
Which one are you interested in?
No, the last slides. The last one. With the conclusion. Sorry.
Conclusion. Yeah. Okay.
Oh.
Yes.
You showed that patients with supraventricular ectopic arrhythmia actually these are the patients where you found reversible ischemic events. Yeah.
Yes.
So in this group, you have analyzed. Did the patients also receive the antithrombotic treatments?
In this study, we were focused on analyzing the Holter tests and general characteristics of the patients. We are planning to include treatments and medicines given for the patients, and that may change the results or expand them in some ways.
Okay, thank you.
Thank you very much.
Thank you. Now I would like to ask to present the paper entitled Age as a Predictor of Immediate and Long-Term Changes in Ventricular Function in Marathon Finishers.
Good morning, ladies and gentlemen. Thank you very much for invitation. Dear jury, dear colleagues, my name is Marcin Schulz, and I want to present results of research carried out by Talent Scientific Group in 2nd Department of Cardiology in Zabrze. To introduce, aging is often accompanied by decline in physical capacity, but regular exercise can attenuate some of these effects. So this is an important issue to encourage patients to do sports activity so as to improve their health and prevent cardiovascular diseases, and not only. Coming into our research, the available data on the function of heart muscle in amateur marathon finishers, depending on age, is limited. So through advanced echocardiography, we aim to discern any age-related differences in ventricle function immediately post-race and during follow-up. 105 participants of Silesia Marathon of 1st October 2023 were enrolled. The runners aged from 22 to 70 years have been divided by a median value of 42 years into younger and older groups. Two-dimensional echocardiography have been performed at baseline, post-race, and during follow-up. At all phases of research, left ventricle ejection fraction, left ventricle global strain, right ventricle global strain, and tricuspid annular plane systolic excursion were measured. Results were stored in the database for further analysis. Our scientific group was involved in developing results. We've been working with EchoPack workstations by GE Healthcare. For statistical analysis was used non-parametric Friedman ANOVA. Results are presented in the table. A statistically significant difference was observed in older group for LVEF at all 3 time points, at baseline, post-race, and during follow-up. LVEF values did not differ statistically in the younger group. Similarly, RVGL's values at all 3 time points and TAPSE values at baseline, post-race, and follow-up differ statistically. TAPSE values and RVGL's values in younger group did not differ statistically. RVGL's values for both groups at all 3 time points did not differ statistically. In our research, we want to assert that older participants were more liable to changes in heart muscle function in contrast to younger, and furthermore, there were incomplete recovery in this specific group of patients. To conclude, in contrast to younger athletes, the older age in amateur finishers is associated with transient deterioration in left and right ventricle function. This might explain the reduced physical capacity in elderly population. And further research might help to understand the slower recovery of right ventricle function and longer physical recovery of older amateur athletes. On the photo, you can see our research team. And thank you for the attention, and we invite to the discussion.
Thank you for your presentation. Can you tell us what was your contribution to work?
Yes, of course. Me and my co-workers from our research team have been present on the stadium and at the end of September last year for 4 days during participants' registration Then we helped our doctors to proceed examination at baseline. And then on the 1st October, all members of our research team were present. After the finish of marathon, participants were examined immediately post-race. And then we were in our clinic during examining patients. And then from October last year to February this year, we have been working with EchoPack software to prepare results, and then we prepared statistical analysis. I prepared today's presentation and my speech.
Okay, thank you very much. Now we can move to the discussion.
Congratulations for you and your colleagues of the fantastic topic and huge work. Congratulations. And could you tell us the explanation of prolonged recovery of RV function after in elder patients after running?
Thank you for your question. We truly believe that our studies are valuable, and we know that future researchers are needed to, for example, make the group of exact patients with no return of heart function and long recovery, which was before the run, and we are going to invite them and examine in our clinic with the broadened package of analysis, including three-dimensional echocardiography.
And is this topic discussed in literature, or it is new one?
And
because for me it's very new and fantastic.
It's really new.
Fantastic observation.
Yes,
thank you.
and we are focusing on excluded this to in Poland and in others conferences in Poland, and not only because of the low amount of others researchers in literature, and focusing on aging, because this is really limited.
And nowadays, fantastic topic. Thank you.
Thank you very much.
So my question is about this group above 42 years, because the median was 42, so it means that 50% of participants were older than 42 years. So it is advanced age for a marathon. Who allowed the participant, for example, the oldest was 70 years old. Who allowed for such person to participate in the marathon? It's normal. For me, not.
So we don't have information who let the people in such an age start, but I think that's why we choose a group from like Silesia Marathon, because we have like amateurs and pro runners and 22-year-old and 70-year-old people.
So how many persons stopped preliminary marathon in the younger and in the older group?
We don't have any information about this.
About this, okay. But also
because it wasn't our aim of the study.
I think it depends of training.
Just a short explanation, because I was somehow involved in this work. Actually, there is no age limitation for the runners. All the participants of the not only Silesia Marathon run, but other events in Poland. There is actually no regulation, no age limit. There is no preliminary examination. The patient just sign a piece of paper that will take responsibility for the health, and it's responsible that everything might happen, and is by signing it simply says that it's healthy.
Yes.
That's all.
And this is liberty.
Yes, it's liberty.
Yes, of our decision. And
but every year one of them is admitted to hospital with CPK levels of 15,000 or more, even because of their disruption of muscles. And usually it's during the second leg, so it's during about 30 kilometers of running. These cases are regular. But they don't finish. They are not included in your study, of course. Thank you.
I think we should encourage the older patients to be active.
Okay, thank you very much.
Thank you.
Now I would like to ask to present the paper entitled Arrhythmogenic Right Ventricular Cardiomyopathy, Patient's Pathways to Diagnosis.
Good morning, ladies and gentlemen. My name is Karolina Figel, and today I have a pleasure to present our study about patients' pathways to diagnosis of arrhythmogenic right ventricular cardiomyopathy. So for a start, I would like to tell you about this disease. Arrhythmogenic right ventricular cardiomyopathy is a genetically conditioned disease characterized by fibrofatty replacement of myocardium, which leads to potentially life-threatening arrhythmias. Aim of our study was to analyze the course of the diagnostic process in patients with ARVC, and also to assess the differences and the course of the diagnostic process between younger and older patients with ARVC. We conducted a retrospective analysis of 26 patients who were hospitalized between 2003 and 2022 in first department of cardiology. We divided them into two subgroups based on age at the time of diagnosis. Here we have closer look at characteristic of the study group. As I mentioned, it numbered 26 patients, including 7 females and 19 males. The Y group was younger and consisted of patients who are between the ages of 10 and 39 at diagnosis, and the patients who were older than 40 years old at diagnosis were in the O group. And the subgroups consisted of 10 and 16 patients, respectively. We analyzed symptoms that cause hospitalization, such as palpitation, exercise intolerance, and syncope. and results of ambulatory examination like ventricular arrhythmias, ventricular tachycardias, and atrial fibrillations. We also analyzed type of hospital admission, whether it was elective or urgent, and cardiac family history. Moving on to the results, we established that mean age of diagnosis was 46.7 plus or minus 17.2 years. As for type of hospitalization, 65.4% were elective and 34.6% were urgent. On the diagram, we can see frequency of symptoms that led to diagnosis. Most common ventricular arrhythmia, 96.2%, followed by ventricular tachycardia, then exercise intolerance, palpitation, syncope, and the last atrial fibrillation. Two of our patients had a positive cardiac family history. In one case, it was sudden cardiac death at age 38, and in other, it was myocardial infarction at age 36, both in first-degree relatives. The comparison of the age-divided subgroups revealed significant differences in terms of palpitation, which occurred in 80% of Y subgroup and 25% of O subgroup, and exercise intolerance, which occurred in 30% of Y subgroup and 81.3% of O subgroup. Other analyzed symptoms and factors were statistically insignificant in terms of age. In conclusion, the diagnosis of ARVC is made late, by which the disease is already in an advanced symptomatic stage, probably making it difficult to treat. It is important to keep this disease in mind while diagnosing younger patients with ventricular arrhythmias, and positive family history was not a significant factor in our diagnostic process, despite the fact that ARVC is genetically conditioned disease. And thank you for your attention.
Thank you very much for your presentation. Can you tell us what was your contribution to the work?
As for my contribution to the work, in our group, we researched the informations about ARVC. We collected data from patients' medical history. We performed statistical analysis and made this presentation, and today I presented it.
Thank you. Now we can move to the discussion.
Could you, congratulations, could you tell us about the diagnosis of arrhythmogenic cardiomyopathy, right ventricular, in which criteria it was based?
Thank you for this question. Patients which history we studied, they had their diagnosis based on task force criteria.
From which year?
This modified task force criteria
the
from 2020.
Yes,
yeah.
Thank you. Tell us.
Congratulations for this analysis. It's not a substantial number, but I think these are the consecutive patients collected from almost 20 years. Yeah, 2003. There was the first, as you saw, admission. The results you showed are quite striking, because it seems that most frequent symptom, this was ventricular arrhythmia, tachyarrhythmia. What about imaging signs. Does it mean that imaging was not done in these patients and does not have any significance? What would be your comment? Should we scan these patients, and what will be the list of signs that are typical for arrhythmogenic cardiomyopathy?
Thank you for a question. Actually, our patients had, of course, ECG, but also echo imaging and MRI of heart. This was used to give them diagnosis, but we wanted to study the first symptoms for them. What are the first symptoms that patient feels or come to a hospital with, so we can see which factors we have to focus on. So they had imaging and other studies, but we didn't want to focus on that in our study, because this is more advanced in the process of diagnosis.
What about the asymptomatic patient? Because patient may not feel any arrhythmia, but
yes,
find something in echo.
Yes, so we thought that maybe family history can be assigned to observe patients, but it seems that positive family history is not significant to diagnose or treat this disease. So actually, I'm not sure how to diagnose asymptomatic patients. It's I think that we cannot tell at this point.
Maybe family history is the point.
Yeah, maybe, but our patients didn't have a genetic history.
But family history is not only genetic.
Yes, yes.
A little bit, maybe I missed it in your conclusions, but in your first conclusion, there is that in older age it's more difficult to be treated. Yes? Mm-hmm. Why? I don't understand that. For me, it's more difficult to treat younger patients.
We thought that it can be more difficult because of advanced stage of this disease, because of more more tissue of the heart could be changed for fibrofatty tissue.
It is okay. I understand, but still, you make the analysis at the point of diagnosis, yes? So diagnosis in later age seems more favorable outcome because they don't have some limitations in young age. When somebody is diagnosed in young age, it's more for him more crucial for the rest of his life. That's my opinion. Thank you.
Thank you for this point of view.
And I think this last question, a very short question, because you said, and it was on the slide with conclusions and with results that ventricular arrhythmias in Holter recording was the most frequent and the most common symptom in this group, yes?
Yes.
But the question is, how did you define the ventricular arrhythmia? Because you separately had information about non-sustained ventricular tachycardia. And this is very clear for me. But what does it mean, ventricular arrhythmia?
Okay, thank you for a question. We defined ventricular arrhythmia as any ventricular arrhythmia, as for some of our patients.
One premature ventricular contraction per day is important or not important?
Can you repeat?
Because you said that any ventricular arrhythmia, so one premature ventricular contraction per day is important or is not important?
Yes, it's important.
So we all have important ventricular arrhythmias.
I don't know. Because some of our patients was admitted with, for example, ventricular fibrillation.
Yes.
Yeah, so we counted it as ventricular arrhythmias. Mm-hmm. So that's what we meant with this.
Okay, it's still not clear for me, but okay.
Okay, thank you.
Thank you.
Now I would like to ask to present the paper entitled NT-proBNP level as a marker of heart failure in patients with pulmonary arterial hypertension.
Good morning, everyone. My name is Wiktoria Laskowska, and I am incredibly pleased to present to you the results of our team's study from the non-invasive cardiology field. Our work's topic is NT-proBNP level as a marker of heart failure in patients with pulmonary arterial hypertension. After introducing our topic, I will move on to describing materials and methods we used. Then I will present the results and finish my presentation with conclusion and discussion. N-terminal pro-B-type natriuretic peptide, also known as NT-proBNP, is cleaved from BNP secreted by the heart ventricles. It's produced in excess when the heart struggles to work harder than usual. Therefore, it's a valuable marker used for diagnosis and risk stratification in heart failure. Is NT-proBNP level always reliable? Unfortunately, there are several factors that may influence its level and reduce diagnostic usefulness of this marker. The aim of our study was assessing the impact of commonly occurring clinical factors on NT-proBNP level among patients with symptoms of heart failure and pulmonary arterial hypertension. Our study was a retrospective, tertiary, single-center analysis. We gathered data from 60 patients with symptoms of heart failure and pulmonary arterial hypertension. 32 were males, 28 were females, with their mean age being 60.3 years. Our patients' mean BMI equaled 27.5 kilograms per square meter, and the average duration of hospitalization was 4.4 days. The exclusion criterion for the study was a history of pulmonary embolism. Here is a list of comorbidities and laboratory test results that were taken into consideration. 88.3% of patients were admitted as planned. On the other hand, 11.7% of patients showed symptoms of decompensation on admission, such as dyspnea and peripheral edema. These graphs show the distribution of different NYHA classifications among all patients, males and females separately. In our study group, average NT-proBNP concentration was 2,502.3 picograms per milliliter, with a median value of 1,473 picograms per milliliter. Average NT-proBNP level was higher among women, decompensated patients, and those who were hospitalized for longer periods of time. The comparison of patients in different NYHA classes revealed that obviously patients in class 4 were having the highest values. The comparison of patients with NT-proBNP levels below and above the median level exposed some differences: more frequent males, older age, worse kidney function, and longer hospitalizations in subjects with NT-proBNP level above the median. After analyzing the collected data, the following were noticeable. Some of the correlations obtained were undeniable. Patients with lower stage of heart failure progression in the NYHA classification, patients admitted for planned hospitalizations, and those whose heart failure wasn't in the compensation state were characterized by lower values of NT-proBNP. Nevertheless, acquired results do not confirm correlation between mean NT-proBNP level and mean pulmonary artery pressure. Moreover, the results displayed the influence of renal function on NT-proBNP level. It's strongly correlated with creatinine level and estimated glomerular filtration rate, specifically among males. Speaking of the less obvious correlations, our attention was drawn to the lipid profile of analyzed patients. Our results show that higher HDL level contribute for lower NT-proBNP concentration, and there's also a slight correlation with LDL level among men, but there was no relationship with triglyceride concentration. Anemic patients tended to have higher NT-proBNP values. And there was strong correlation with hemoglobin level, but no correlation with serum iron level, perhaps due to lack of data in all patients. Among the comorbidities considered, our results definitely confirm strong correlation between the presence of chronic kidney disease and higher NT-proBNP concentration. There's also a slight correlation with a history of myocardial infarction in women, but there were no significant correlations with arrhythmias, chronic obstructive pulmonary disease, and history of neurological disorders. So we can conclude that, presumably, they don't influence NT-proBNP concentration. This chart shows a quick comparison of two groups of patients isolated from the whole study group. Group A with 3 risk factors for increased NT-proBNP concentration, and Group B with the opposite factors. The comparison confirmed that patients from Group A had a mean NT-proBNP concentration almost 4 times higher than the average in all 60 patients. Meanwhile, in Group B, mean NT-proBNP level was close to 2/3 of the whole group's average level. To conclude, NT-proBNP level is an efficient marker in heart failure because ordinarily it corresponds with clinical state and heart failure progression. However, it should be noted that certain conditions affect its level independently of the above. Our take-home message is to recognize these factors when evaluating a patient with heart failure. I sincerely appreciate your attention today. Here is a list of websites and articles which we used, and if there are any questions, I'd be happy to open up a discussion and ask my coworkers to join me. Let me start with our contribution to the work. We tried to do everything as a team. We all have the same contribution. Firstly, we talked it over with our works tutor to decide on which factors are we going to analyze. We gathered data, created a database, and analyzed our comorbidities, laboratory test results, their correlations to NT-proBNP level. We prepared the abstract and the presentation displayed on the screen today.
Yeah, thank you for your presentation. Now we can move to the discussion.
Thank you for your presentation. NT-BNP in heart failure, we know, has a prognostic meaning, specifically for the left ventricle heart failure patients. And we know that NT-BNP correlates very closely with reverse remodeling. So it might be very good prognostic markers in terms of effectiveness of our treatment. How about the right side of the heart? You looked at patients with primary hypertension, so this is a very good clinical model of pulmonary hypertension. I'm not striking with correlation with renal function because cardiorenal syndrome is a natural consequence of right heart failure. Did you also try to look at hepatic function, because some of these patients at certain stage of the disease will develop for sure the cardiohepatic syndrome. So it would be interesting to look whether there is a correlation with some of hepatic measure. And the last thing, what about volumetric measurements? Because you didn't touch this measurements. Do you think that anti-BNP also have a prognostic significance in terms of looking at effectiveness of the treatment? Because all these patients, I presume, were in a pharmacological program. So how could you comment about this role of anti-BNP as a prognosis in these patients?
Thank you for your observation. Firstly, we didn't analyze a correlation with liver diseases such as liver cirrhosis, because we had only 60 patients, because our disease is not so commonly diagnosed, and more of them have chronic renal disease, so our correlations were more significant. A very few of our patients had diseases such as liver cirrhosis, so this data was just not so good to analyze. And about, can you please repeat the second part of your observation? About correlation with volumetric
the question about
measurements?
Cardiohepatic syndrome and the measurements of the hepatic measures. So the total bilirubin.
Oh, okay. No, we actually didn't analyze it, but anyway, it wouldn't fit into this 7-minute presentation, but we think it's a great idea to explore it in our further analysis.
Did you try to look at reverse remodeling of the right ventricle? So did you measure the volume of the right ventricle?
We also analyzed correlations with ejection fraction
and diameter of the.
We only analyzed ejection fraction and right ventricular systolic pressure. Yes, we didn't put it on the presentation, but yes, we obtained positive correlations. That yes, anti-proBNP is significant marker.
It's striking that you didn't find any correlation between the level of anti-BNP and the mean pulmonary pressure.
Yes, nevertheless, we didn't acquire it, but presumably the small group of patients contributed to this. Maybe we can explore this field in the future.
Could you clarify what kind of glomerular filtration rate formula was used in your data? To assess eGFR?
I don't think
it was MDRD or some kind of more advanced formula?
No, I don't think it was a more advanced formula. It was just the regular.
Don't you think that it will be useful to use a formula which is based not only on age and gender, but also on weight of the patient?
I think we use the formula based on the age, weight of patients, and creatinine level. I'm sorry we didn't put it on our slides, but thank you for this observation. Dear committee, thank you for your questions, and thanks to everybody for your attention.
Thank you very much. Now I would like to ask to present the paper entitled Are there any factors influencing successful electrical cardioversion in patients with atrial fibrillation?
Good morning, ladies and gentlemen. My name is Monika Bączek, and I am honored to present you our work titled Are there any factors influencing successful electrical cardioversion in patients with atrial fibrillation? I want to begin my speech with a short background. So atrial fibrillation is the most common arrhythmia in adults. It is estimated that approximately 1 in 3 people will experience atrial fibrillation during their lifetime, and the risk of its occurrence increases with age. On the ECG, atrial fibrillation is presented as the lack of the P wave and a complete arrhythmia. One of the simple methods that helps us dealing with atrial fibrillation is electrical cardioversion. It is based on an energy use to achieve a conversion to the sinus rhythm. The maximum fixed energy electrical cardioversion has higher effectiveness than an energy escalation strategy. And as you can see, the electrical cardioversion is a recommended method of treatment in symptomatic patients with atrial fibrillation. I would like to present you how many risk factors and potentially causes have atrial fibrillation. So we decided to analyze it all and think about the relationship between the presence of atrial fibrillation risk factors and the success of electrical cardioversion. So the aim of our study was to assess efficacy of elective cardioversion in patients with atrial fibrillation. We also want to assess the relationship between the presence of atrial fibrillation risk factors and the effectiveness of electrical cardioversion. And finally, we analyzed the energy used during electrical cardioversion to convert sinus rhythm. Moving on to the materials and methods, our study was a single-center retrospective analysis of patients hospitalized in the first department of cardiology in years 2019 to 2022. There were 311 patients, and they were selected using the exclusion and inclusion criteria. Then we collected an anonymized clinical data from patients' medical history. Analyzed parameters involves general information, comorbidities and risk factors such as, for example, smoking, also echocardiography parameters and results of laboratory tests. Finally, we analyzed used energy during electrical cardioversion, the return of sinus rhythm and heart rate before and after electrical cardioversion. Our study group consisted of 311 patients undergoing electrical cardioversion due to the atrial fibrillation. In all cases, it was an elective cardioversion in patients with persistent atrial fibrillation. Most of our patients were male and the mean age was 68 years old. The obesity was diagnosed in 30% of the patients. Based on the successful of electrical cardioversion, we divided our study group into two subgroups. The first one was successful electrical cardioversion subgroup with 283 patients, and the second one was unsuccessful electrical cardioversion subgroup with 28 patients. Moving on to the results, as you can see in both of this subgroup, the sex and age structure was similar. There were no significant differences, including CHA2DS2-VASc score, weight, and height in these two subgroups. Also, there were no significant differences in comorbidities and smoking, but there were no significant differences with echocardiography results, but we find out that there is a correlation because the presence of obesity and the result of electrical cardioversion. It turned out that obese patients have a lower chance to obtain a sinus rhythm conversion during electrical cardioversion because and this group obese patients is more numerous in unsuccessful electrical cardioversion subgroup, and the p-value was 0.046. We analyzed also the maximum energy used during the cardioversion, and we noticed that in patients with successful cardioversion, the energy equal 150 joule was the most the best, but on the other hand, with the subgroup with unsuccessful cardioversion, in 38% of patients, there were no attempt to use the maximum energy during electrical cardioversion. So the chances to return sinus rhythm in this group of patients were lower because there were no attempts to use the maximum energy. Now I would like to move on to the conclusions of our work. So the electrical cardioversion is an effective method for the sinus rhythm conversion in patients with atrial fibrillation. Obesity is one of the relevant factors which decrease the effectiveness of electrical cardioversion. Before planning electrical cardioversion, a BMI lower than 30 should be obtained because it might affect the effectiveness of electrical cardioversion. And if the previous electrical cardioversion attempts at lower energies were unsuccessful, attempts to use higher energies should be made. Ladies and gentlemen, this brings me to the end of my presentation. Thank you very much for your attention, and please feel free to ask me some questions.
Thank you very much for your presentation. Can you tell us what was your contribution to the work?
We have to get acquainted with the available literature about electrical cardioversion and about atrial fibrillation. Then we move on to the creation of our database. We need to select the patients using the including and excluding criteria. We analyzed more than 400 patients, but only 311 was included into our study. Then we collected every data, including general information, laboratory parameters, echocardiographic parameters, comorbidities, risk factors, also parameters about cardioversion and the time of type and time of atrial fibrillation. Then we performed a statistical analysis of this data, and we move on to the preparation of the abstract and the presentation for our conference.
Okay, thank you. Now we'll move to the discussion. Are there any questions?
Congratulations. Do you have any clues why this maximal energy was not used in these patients, in this part of patients?
Unfortunately, we have no idea. We have discussed it also with our tutor, and there is no reason why there were no maximal energy attempts made. There were also no information in patients' medical history, so we know what is the reason why in some patients there were no attempts to use the maximum energy, but we think that it's not good for the patient because the chance to obtain sinus rhythm conversion is lower.
Thank you. One more comment. One of your conclusions is to get patients be thinner. It's not easy to reach. So probably the time to cardioversion, which is even planned with no acute symptoms, is too short to reach the lower BMI level. Thank you.
Congratulations. A large group and very simple but important clinical conclusion. Thank you.
Thank you very much for the question.
You analyzed a lot of important parameters, but in statistics, maybe I didn't notice, but there were no the type of atrial fibrillation and the duration time of atrial fibrillation.
So all of the patients were patients with persistent atrial fibrillation, and yeah, because this was one of our inclusion and exclusion criteria. And we also tried to analyze the duration of atrial fibrillation, but there were lots of lacks of database, so we didn't included into our final analysis and to our presentation.
But it is one of the most important parameters which needed to be analyzed in such a situation. Okay, thanks.
I have one question, because you said that all these patients had persistent atrial fibrillation, and what about medical, especially antiarrhythmic treatment? Do you have any data about it? Because some antiarrhythmic drugs can help with positive to obtain positive cardioversion. For instance, chronic treatment with sotalol or amiodarone.
Yes, we analyze the use of, for example, beta blockers and amiodarone and also busotal, but there were no significant differences between groups using this treatment and without this treatment.
Yes, I know. Okay, fine. You have data, because it's very important. The statistic is very difficult, because we have 9% of unsuccessful cardioversions and 91% of successful, so it's 10 to 1. So this statistic is very, very difficult in this situation when you have two other variables, for instance. Okay.
Thank you very much for these questions.
Thank you. Now I would like to ask to present the paper entitled "Do We Treat Well? Assessing the Effects of Mono and Polytherapy in PAIH Treatment."
Good morning, ladies and gentlemen. My name is Oskar Woźniak, and I would like to present to you our research result of comparison monotherapy and polytherapy in treatment patient with pulmonary arterial hypertension who died. Pulmonary arterial hypertension is a life-threatening disease leading to right ventricular hypertrophy, right ventricular failure, and ultimately death. New guidelines recommends to start treatment from polytherapy. Only half of patients survive more than 5 years. And the aim of our study was to assess the effectiveness of PAH treatment by comparing regimes between patients who died receiving polytherapy or monotherapy. We also want to determine the characteristic of the population that died from PAH. We have analyzed medical data of patients under the care of our cardiology clinic, who was patient who died between 2011 to 2024, and we divide this patient into two groups. One group who was treated by monotherapy on the last visit, and other group with polytherapy treatment. We exclude patients with less than 2 visits to the clinic before death, and those with no treatment implemented. And also we, in our statistical analysis, we used T-student test, human Whitney test, and also chi-squared test. We have analyzed parameters as medication, age, NYHH class, NT-proBNP, duration of treatment, and also echocardiography parameters. We include in our study 34 patients in mean age 58, and they were mostly a woman. And the reason of the lack of PAH therapy escalation was a lack of consent, comorbidities, and no compliance. In group M, there was 12 patients in mean age 59.5, and group P, there was 22 patients with mean age 57.8. Average NYAH class and NT-proBNP on last visit was higher in group P. Duration of treatment was higher in group M, but there was no statistical significance difference between these two groups. IT centimeters square and RVSP was higher in group M. TAPC and TAPC RVSP was higher in group P, but there was also no statistical significance difference. Only exception was IT grade, which was higher in group M, and it was statistical significance difference. NT-proBNP increase in both groups from the first visit to the last visit. What about conclusions? The mortality rate was 49% in population of patients with PAH in observation period. Most of the deceased patients were women. Over 30% of patients were treated for a long time using the monotherapy. Taking in regard that monotherapy was used in patients with less symptoms, the lack of difference in survival duration is evidence that show us that polytherapy should be used in all patients. What would we like to remember from this study? If patient has no comorbidities and is in a good clinical condition, we should start treatment from polytherapy. Thank you for your attention.
Thank you for your presentation. Can you tell us what was your work? What did you do to the study?
We have collected data of this patient, and we have analyzed, statistical analyze this data.
Okay, I think we can move to the discussion. Are there any questions?
Only my conclusion is that nowadays we know that polytherapy is much more better than monotherapy. I'm so sorry. In PH, the same in heart failure. And I don't know, but I think you should prove it in the next studies. I think it works, and I am very optimistic of polytherapy and started up to now all medical treatment. For me, it's very important, but of course, it needs more studies. Thank you.
Yes, we think the same.
Yes, yes.
It will be comment on the question because you are talking about mortality in this group of patients, and we saw many data, very important data. But if we are saying about mortality, we have to think about arrhythmic death, about sudden cardiac death. And I didn't see, I haven't seen, maybe better, I haven't seen any data about cardiac arrhythmias. how many atrial fibrillation was observed in this group of patients? How many malignant ventricular arrhythmias? What about ventricular arrhythmias at all?
We didn't collect that data.
So it was very good to collect it, because I think it may be very important, especially when we discuss about mortality. It's my opinion, of course.
Thank you.
Okay, thank you. Okay, now I'd like to ask to present the paper entitled Temporal Left Ventricular Ejection Fraction Variations Predict Survival in Patients with Heart Failure.
Good morning, ladies and gentlemen. My name is Jakub Sokołowski. I'm the third-year student of Medical University of Silesia, and the topic of our work is temporal left ventricular ejection fraction variations predict survival in patients with heart failure. The work tutor is Maciej Wybraniec. Currently, the incidence of heart failure is 3 per 1,000 person years in all age groups and 5 per 1,000 person years in adults. The prevalence of heart failure is from 1 to 2% among the adults in Europe. And the 5-year mortality rate ranges from over 50% to almost 70%. The left ventricular ejection fraction is the main prognostic factor of mortality among the patients with heart failure. The aim was to assess the predictors of mortality in large cohort of patients with cardiovascular disorders with a focus on heart failure with improved ejection fraction. We acquired the data from the database of Academic Repository of Clinical Cases of Medical University of Silesia. Our inclusion criteria were at least 2 echocardiographic measurements of left ventricular ejection fraction separated by at least 1 month, and diagnosed cardiovascular disorders consistent with International Classification of Diseases. Our primary endpoint was all-cause death, confirmed by the data from national healthcare provider. We defined heart failure with improved ejection fraction as the maximal increase of left ventricular ejection fraction by at least 10% in relation to the baseline value in patients with established heart failure diagnosis. And in patients without this diagnosis, we defined this improvement of ejection fraction as left ventricular ejection fraction 10% maximal increase. Here is the mentioned list of cardiovascular disorders, and now let's talk about the results. We analyzed 31,920 patients whose median follow-up time was 51.5 months. The median age was 71 and mortality during the follow-up 6.6%. Our cohort consisted of 37.7% of women, and heart failure occurred in 38.1% of patients, among which 46.9% had reduced ejection fraction and 41.5% had preserved ejection fraction. We've also analyzed some different disorders like hypertension, ischemic heart disease, diabetes, atrial fibrillation. We've also analyzed some continuous parameters in our patients, and for example, the mean GFR was 72.1, and it was MDR GFR. The CHA2DS2-VAS score was 3.2. Mean left ventricular ejection fraction was 49, and the mean number of measurements of LVEF was 3.2. The Pearson chi-square test comparing patients with heart failure to patients without heart failure showed statistically significant difference in the distribution of sex, atrial fibrillation, hypertension, diabetes, dyslipidemia, chronic kidney disease, myocardial infarction, and finally in the mortality, all with p below 0.001. The Kaplan-Meier curve for overall population show statistically significant difference in survival probability between patients with the decreased ejection fraction by at least 10% in relation to patients with the stable ejection fraction, that means from -10 to +10%, and increased ejection fraction, that means over 10%, all with p below 0.001. What's interesting that in overall population as well as in the non-heart failure population, patients with stable ejection fraction have higher survival probability than patients with improvement of ejection fraction. However, in the heart failure patients, there is a switch. So now the highest survival probability is among the patients with increased ejection fraction, but again, the lowest survival probability is in the patients with the decreased ejection fraction. And as I mentioned, in non-heart failure patients, stable patients have higher survival probability than patients with the increase, and patients with the decrease have, again, the lowest survival probability. Now let's talk about the Cox proportional hazards model. So here is the list of mortality predictors in overall population. And what is most important for us is that left ventricular ejection fraction 10% maximal increase was an independent positive predictor of mortality in the overall population with p below 0.001. In heart failure population, patients with heart failure with improved ejection fraction have the highest, the heart failure with improved ejection fraction is an independent predictor of mortality with p below 0.001, and however, in non-heart failure patients, left ventricular ejection fraction 10% maximal increase is not the predictor of mortality. Here is the comparison in mortality between patients with improved ejection fraction by 10% in comparison to patients without the improvement in two groups of patients. In non-heart failure patients, okay, it doesn't work. In non-heart failure patients, mortality is higher in patients with the improvement of heart failure. However, in the heart failure patients, it's the opposite. So now patients with the improvement of ejection fraction have lower mortality than those without the improvement. Now let's talk about the conclusions. Left ventricular ejection fraction variability is prevalent in patients with various cardiovascular disorders and in patients with the diagnosis of heart failure. Heart failure with improved ejection fraction defined as the maximal increase of left ventricular ejection fraction by at least 10% predicts survival in patients with established diagnosis of heart failure. In overall population and patients without heart failure, patients with stable left ventricular ejection fraction have better prognosis than patients with left ventricular ejection fraction variability. That means the increase or the decrease. And finally, the heart failure with improved ejection fraction represents a newly recognized subtype of heart failure related with improved prognosis, which may drive decision-making process in heart failure management. Thank you for the opportunity to present today, and thank you for your attention. And if there are any questions, let me know.
Thank you for your presentation. Can you tell us what was your contribution to the work?
Yes, of course. So basically, we were mostly responsible for preparing the database because it's very important to notice and highlight that data downloaded from the clinical repository is pretty much unusable just like that. It needs to be sorted out, it needs to be checked, and especially in such a large cohort, there was pretty great work. We needed to use, for example, some Excel formulas to extract the numerous data like left ventricular ejection fraction from the text, from the epicrisis, from the patient's history, and then we needed to check everything. So we basically needed to check each one patient of this 31,920 patients, and even more because some of them were excluded. Basically, if mean measurement was 3.2, then we needed to check around 90,000 left ventricular ejection fraction numbers. And we've also needed to check epicrisis, all epicrisis, and all history to check if patients with hypertension have arterial hypertension and not, for example, pulmonary or portal hypertension, because there is a great variability in coding those things among the doctors, because these are basically the data from the hospital, 2 hospitals. And then we were preparing, for example, forest plots and some charts. Here we were also involved in the analyzing of the data. However, we want everyone to know that we didn't prepare the statistic itself. It was done by our tutor, Maciej Wybraniec. And finally, we were preparing the data here and the whole presentation.
Okay, thank you. I think we now can move to the discussion.
Thank you for your presentation. This is just an example of the big data analysis. The first question is are these data collected at one center, or this is a multi-center analysis? Second question is related to your final conclusions about the new type or subtype of heart failure. So patients with improved ejection fraction. Yes?
Yes, you mean if the survival probability of patients, or what? Again, can you repeat the question?
Because you proposed a new definition of a subtype.
Of patients with heart failure with improved ejection fraction,
yeah.
right?
Yeah.
Yes, there is, as we've seen in, for example, the meta-analysis of this from our tutor, in history there were plenty of definitions of heart failure with improved ejection fraction, because that is quite a new subtype of heart failure, and some of them take 5%, even 5% of improvement as the improvement of ejection fraction. Some take 10%. We decided to take the 10% improvement to the baseline as quite narrow definition. However, that allows us to change it, for example, in the further studies and check what is going to change.
I wanted to say just that we can look at heart failure cohorts in different way. Reverse remodeling, it's a natural process in this group, and we can, as you showed, apply the changes in ejection fraction, but we can also look at the changes in diastolic and systolic volume. And there's enough data that shows that these parameters also have a prognostic value. And as you underscore that there is no strict criteria how we should define reverse remodeling. So that 10% is somehow arbitrary value. So we agree about that. So my first question was, is this a one center or is this a multi-center analysis?
No, this is just, we were preparing this study just with our tutor here in University of Silesia, if that's what you're asking.
Repository, okay.
One question, because you had on the third or fourth slide CHA2DS2-VASc. You calculated the this CHA2DS2-VASc score for all these patients.
We were during the analysis. We were analyzing that in patients who's got this put in the epicrisis or in the history. We've also tried during these statistics to count it from, for example, the informations that we get provided, like hypertension and all the other parameters that are included in the CHA2DS2-VASc score.
So
we've also tried to. CHA2DS2-VASc was especially important because we were trying also, but in the wider part of our study to analyze the predictors of MACE occurrence and ischemic stroke. So that was more important to those analysis. However, it didn't make into the presentation due to the limitation of time.
Mm-hmm. I understand, but I ask about CHA2DS because CHA2DS score can be also used in prediction of sudden cardiac death, for instance.
Yes, so our definition of MACE when we were analyzing it was that it is the first of the three endpoints that is occurring in the patients, and the endpoints were death, was ischemic stroke, and was death, stroke, and sorry, I don't remember this one.
Okay, never mind then. Okay, fine.
Which years did you include to the analysis from this database?
Excuse me, can you repeat?
Which years?
The data from the repository is including very various people whose we don't exactly know, for example, who's each particular patient, when was he treated. We only know how long was he treated and what is like the time period between the data of the first echocardiographic measurement to the last information about patients, for example, the data of admission from the hospital, or for example, the data of death from national healthcare provider. So I don't know exactly from where is the first, for example, data about the patient in the repository.
Okay, thank you. Okay, now I would like to ask for the presentation of the paper entitled Correlation Analysis of Biomarkers and MRI Changes in Children with Suspected Myocarditis.
So hello, ladies and gentlemen. My name is Zofia Biegun, and I'm an honor to represent the Department of Pediatric Cardiology and Congenital Heart Defects in Zabrze. And I'm going to tell about the correlation analysis of biomarkers and MRI changes in children with suspected myocarditis. Firstly, let me make a short introduction into the topic of myocarditis and its etiology. As you can see on the diagram, an autoreactive response seems to be crucial in the development of myocarditis in children. So if after an infection we observed symptoms of myocarditis, we have to know that it's not only the direct cellular damage by the infectious agent, but mostly it's an involvement of the host's immune system, which starts several days after infection, when the adaptive immune response via antigen-specific T and B cells clears the virus and causes, unfortunately, further damage to myocytes, resulting in progression of fibrosis. Fibrotic changes in heart muscle can cause some really serious problems, such as diastolic and systolic dysfunction, arrhythmias, ischemic heart disease, and it can lead to possibly life-threatening conditions such as heart failure, dilated cardiomyopathy, and even death. So what we have to do is to diagnose this problem as fast as we can, to implement a symptomatic treatment using ACE inhibitors, beta blockers, and aldosterone antagonists, which will protect against this irreversible process of fibrosis. What was the methodology? Each of our patients underwent both MRI and laboratory testing to assess the extent of inflammation, and blood samples were collected to measure the level of cardiac biomarkers such as CRP, troponin T, creatine kinase, myocardial band, and NT-proBNP. We've made a statistical analysis using Statistica software. So now let's move on to our patients. We had 43 consecutive patients suspected of myocarditis who were admitted to the department in the years 2017 to 2024. We had 5 girls, so 88% of patients were male, and median age was 16 years. So based on it, we can suppose that teenage boys seem to be vulnerable in developing myocarditis after an infection. If you are talking about patient symptoms on admission, a majority of them reported chest pains, half of them had fever, palpitation was also observed, and 7% were unconscious. What was important, which makes us think about the etiology of this myocarditis, was that 77% of patients had symptoms of viral infection before being admitted to the unit, and this infection occurred between 1 to 6 weeks before admission. An electrocardiography and echocardiography was done at admission, and we observed an ST elevation in over half of patients. A few patients also had coronarography done to exclude some acute coronary syndromes. We observed also conduction disorders, mainly intraventricular conduction disorders and some bundle blocks. Cardiac arrhythmias too in 12%. It was mostly ventricular extrasystolias. And 26% of patients had decreased ejection fraction in the echocardiography. Lab tests revealed an elevated levels of troponin in 86% of patients, and around 75% had elevated CKMB, NT-proBNP, and CRP levels. In the table, you can see median levels on the first day. Generally, the diagnosis of myocarditis is based on MRI Lake-Lewis criteria, which assess specific signals that you can see in the green box. And in our study, we assessed what we can see in the table, that 72% of patients had an inflammatory process confirmed in heart muscle. Half of patients had edematous changes, 77% had fibrosis, and late gadolinium enhancement as an MRI indication of fibrosis was observed in 56%, and T2 hyperintensity, which can indicate the edema in heart muscle, in 67%. So what results gave us our statistical analysis? We found an inverse relationship between troponin levels and left ventricular ejection fraction, and also between CKMB levels and left ventricular ejection fraction, as you can see on those scatter plots. We didn't find such a correlation between NT-proBNP levels and left ventricular ejection fraction. And we also found an association between troponin levels and myocardial edema, and between troponin and inflammatory myocardial changes. So what conclusions can we draw from our study? We can say that MRI really serves as a valuable diagnostic tool in the evaluation of myocarditis. And based on elevated levels of certain biomarkers such as troponin and CKMB, we can suppose that myocardial contractility is exacerbated, so EF is reduced. And last but not least is that patients with higher troponin levels are more prone to developing myocardial edema. Thank you very much for your attention, and that's all from my side.
Thank you very much for your presentation. Can you tell us what was your contribution to the work?
Our contribution was collecting data in the clinic, making an abstract, writing an abstract, and also making this presentation.
Okay, thank you. I think we can proceed to the discussion. Are there any questions?
I think it's an interesting data set in young patients, I mean, age 16 years. I have the feeling that the clinical course of myocarditis in younger population and adults is different. We have been analyzing also a group of patients with acute myocarditis using pretty the same criteria you have showed us. The lowest ejection fraction was in your group, it was, as I saw, 44%. So actually, I mean, majority of your patient is a patient with just not that advanced systolic dysfunction. What was the clinical course of these patients? How many of them improved completely? And in how many of them there was a deterioration of the function, or if there were any candidates for example, implementation of electric devices?
Mm-hmm. Partly we've done a follow-up, so we know that in majority of patients, the ejection fraction is now normal, and no patient was qualified for transplantation. So generally, those myocarditis were rather not really serious because those ejection fraction at the beginning wasn't really small, just a little bit decreased, as you've said. So generally, now they have visits once a year. Some of them take beta blockers, but generally they are quite good now.
Two small comments. Congratulations first. Then I noticed that one of the patients is 127 kilograms.
Yes.
It's striking a little bit for me. The second comment is that your third conclusion, I don't know what is first, hen or egg. It's a discussion which could be right, but I don't feel that edema is a result of biochemical. It's rather other ways.
Edema, I think, is part of this inflammation process.
Well, so edema is probably the first. I don't know. Well, thank you.
Probably yes. Maybe because of edema, the troponin elevates.
Maybe yes or maybe not. One question for you. Have you data of these patients in electronic version, especially ECG recordings? Have you all these ECG recordings?
Can you repeat?
Can you have you all ECG recordings, electrocardiographic recordings of these patients?
No, we don't have those recordings, but we had only doctors' reviews on those electrocardiogram in the history of.
It's a pity because it could be very interesting to analyze the average or maximal number of leads with ST elevations, especially, and the maximal value of these elevations, and correlate it with, for instance, NT-proBNP or troponin level. But maybe you find this data. No.
Yes, we can find it. It's a really good idea to made it. Thank you very much for your question.
Thank you very much. Now I would like to ask to present the last paper of this session, MVP, more than just a ventricular arrhythmia, impact on the occurrence of atrial fibrillations and thromboembolic events.
Good morning, ladies and gentlemen. My name is Matylda Forszpaniak, and I am a member of research team in Student Scientific Circle at the first Department of Cardiology, studying the impact of mitral valve prolapse on the occurrence of atrial fibrillation and thromboembolic events. On behalf of myself and my colleagues, I'm honored to present the results. But before I start, we would like to thank our tutors, Professor Misia Stec and Dr. Dziadosz, for their assistance and supervision of the project. Mitral valve leaflet prolapse means that the valve flaps don't always fit and close properly. MVP, and I don't mean most valuable player, is associated with the increased risk of sudden cardiac death. In our research, we wanted to assess prevalence of atrial fibrillation and thromboembolic events among patients with mitral valve prolapse and to characterize predisposing factors for these events. Our study utilized data from MIDPRO registry, focusing on patients at the first cardiology department, Upper Silesian Medical Center in Katowice, between January 2023 and April 2024. On admission, patients underwent transthoracic echocardiography, ECG and Holter monitoring, and passed thromboembolic events review. 6-month follow-up included repeated ECG and Holter monitoring and thromboembolic events review. The group of 33 patients included 11 females and 22 males between 18 and 81 years old. It's worth noting that almost half of the population is over 60 years old. Follow-up was conducted for 22 patients due to ongoing study and recent enrollments. Referring to atrial fibrillation, it was detected in 9 patients in total, 8 on admission and 1 at the follow-up. Regarding thromboembolic events, 4 patients were identified upon admission and then 1 during the follow-up period. I'd like to draw your attention to the fact that 80% of the patients with thromboembolic events are males, 2 of whom are also diagnosed with atrial fibrillation. Well, now let me tell you more about our patients. Patient number 1 and 2 are males, characterized by young age and no AF detected, while patient number 1 has a history of ischemic stroke and Marfan syndrome. Patient number 2 was diagnosed with deep vein thrombosis. Another 2 patients are also young men, but not as young as the previous ones. Both of them were diagnosed with atrial fibrillation, but patient 3 had TIA and patient 4 ischemic stroke. Usually ladies first, but today we saved best for last. Patient number 5 is 81 years old, female, with no AF detected, who also developed ischemic stroke, but this time during the follow-up. Unfortunately, during our relatively short study period, we recorded 2 cases of death. Both patients were men over 60 years old with positive family history of SCD, but none of them developed AF nor thromboembolic events. To sum up, according to our study, AF was registered in about a quarter of patients with mitral valve prolapse. Thromboembolic events in this group seems to be related to atrial fibrillation, male sex, and general cardiovascular risk. Regardless of the limited number of patients and short period of observation, the deaths were recorded. Our findings suggest a non-benign character of mitral valve prolapse disease, and there is a need for further studies to prove our observations. Thank you for your attention. Now I would like to invite my colleagues to the stage, and we will be glad to answer your questions.
Thank you for your presentation. Can you tell us what was your contribution as a group to the project?
Good morning, ladies and gentlemen. Nice to see you all. And as for contribution, this was teamwork, and it was a great opportunity to acquire, to develop, and build up our teamwork skills, actually. And an effort we've put in was equal. We were gathering and acquired data from database from a MITPROL registry, and we prepared presentation. We re-examined our patient during follow-up under supervision of our tutor, Dr. Dominika Dziadosz. We as well were process and calculating our results.
Okay, thank you. I think we can move to the discussion. Are there any questions to the presentation? Okay, I don't think there are any questions. Oh, sorry.
Not a question, but a conclusion, because your group is very, very small, and it's very good to, that you said it, and it's very good that in the last slide with the conclusions you wrote it is probable, it seems that it can be related to, because you can find some incident of death or incident of atrial fibrillation, but we don't know if in this group of patients it will be something continuous. So I know that it's very the prolapse, mitral prolapse is very rare, and it is difficult to say anything more about these patients because the groups are always very small. But I think that it is good that some observations started.
Yes, thank you. We were aware of that, and we know that the further studies are needed.
You can't do any statistic.
Yeah, especially that it was only a small group from the whole registry from our department.
Okay, thank you very much for your presentation. All of the submitted papers have been presented. We congratulate all of the presenting authors and participants of the non-invasive cardiology session. At this point, I would like to ask the president of the jury, Professor Tomasz Kukulski, for a few words to sum up the session.
Thank you very much. So now it's time for the conclusion. So first of all, I would like to thank to all participants for your presentations. And I must say that we had an opportunity to hear the results of your teamwork, and as you could see, we had a opportunity to see the different ways of data preparing, data analysis, and different ways of data analysis. So we had examples of work that has been done exclusively by the team from the beginning of the whole concept. We had also examples of sub-analysis of the repository data and also the registries. But I think that the most important thing is the concept of the way how you analyze even the pieces of the big data collection. and the results and the conclusion that you draw based on your analysis. So I still think that the role of a tutor is very important, because the role of tutor is to make inspiration for you. And we had an example that in all of these presentations, the conclusions were drawn very correctly. My second observation is that the English that has been used by the presenters is going better and better each year. So I think it is for you also a good opportunity to train the way of presentation of your data. And the last thing I would like to say is that I would like to encourage you not to stop your work, to continue the analysis, because sometimes the follow-up of the data and longer observations will bring us more exciting results. So do not stop your work, please continue, and I do hope we'll be able to see some of your follow-up results next year. So thank you to all of you, and thank you to members of the jury for your presence, and we are looking forward for the next year students' conference.
Thank you, Professor Kukulski, for these great words. We truly appreciate all the valuable comments, accurate observations, and work on the presentation assessments of the members of the jury. We would like to cordially invite you for the decoration and closing ceremony of the SIMC 2024 conference, which will be held in the Theater Rialto on the 27th of May at 6 p.m. I would also like to invite you for all for the lunch that will be served next to the entrance to this auditorium in the hall at 12, so I think it's being served right now. On the behalf of Student Scientific Society, I would like to thank you all for the participation in this session, and the session is officially closed.